Thank you very much.
Awesome. Yeah, thanks so much, Vanessa. Thanks for having me. I'm a postdoc at Imperial College London now, but I just recently started this position, and so this work that I'm going to present today, it was from my PhD at the University of Calgary, which is why the presentation theme is like this. So in general, my research has focused on bias and fairness of AI models that are used for healthcare. But in this particular work, I wanted to go kind of beyond our conventional approach to this sort of field of study. And so just a bit of background and motivation for people who maybe are not as familiar, but essentially we know that when we have AI models that are trained for use in healthcare, so for example, if we are training a deep learning model to detect disease or some sort of condition based on medical images, we see that oftentimes these models exhibit these performance disparities between subgroups. And so this field has kind of taken off in the past few years where there have been a lot of case examples and studies kind of reporting these in various different applications of AI in healthcare. And essentially, this is concerning because when we have these performance disparities in these systems, there is a chance that that could actually manifest in these systematically different rates of diagnostic errors, different subgroups. And so this could then plausibly end up introducing or propagating or even amplifying disparities that we see in health outcomes. And so this is kind of what this whole area of AI fairness research is really concerned about and focuses on essentially looking at these models and evaluating the performance disparities that they have, as well as trying to mitigate these disparities. So, for example, by intervening on data set characteristics in some ways, or kind of tweaking the model and trying to mitigate bias in the model, such that we end up with these kind of equalized performance rates between subgroups. So this is kind of, this main goal of this whole like field of algorithmic fairness research. But I think it's important to consider that when we're kind of only focusing on these model outputs, we are actually like overlooking a lot of important considerations here. So for example, when we're thinking about our data sets and these subgroups that we're analyzing, like are our subgroups actually meaningfully representing patient populations? With the use of AI in healthcare, this also comes along with these like ethical questions of like, is it actually responsible or ethical to level down subgroup performance in order to achieve this sort of error rate parity? Um, and again, like achieving this sort of equal error rates, is that actually desirable if this model was to be used kind of in a society where we already have these kind of structural inequalities? And so um, these are questions that arise when we think about the actual impact of AI systems on patient populations, rather than just narrowly thinking about our model and its performance. And so in this work, I wanted to kind of dig deeper into this idea and examine this relationship between the technical notions of algorithmic fairness and then the outcomes that are actually experienced by patients. And so this was kind of our goal of this paper, was to kind of explore this connection between algorithmic fairness and patient outcomes. But relating these two concepts to each other does kind of inherently require us to consider this problem through what is called the sociotechnical lens. And so what I mean by this is that instead of just narrowly examining a model as well as its data and outputs, we also need to think about the people and the social structures and the institutions that actually influence this model and its development, and that are in turn affected by it as well. And so the purpose of this paper was to model like not only the AI system, but also the surrounding social context that the system is a part of. And so to do this, we had to essentially model an entire kind of process in the healthcare system. And so in this work, we chose this case example of AI-assisted breast cancer screening. And there's a couple kind of main motivating reasons that we looked at this case example. One of them is that there have been a lot of these AI-based mammographic analysis systems approved or cleared in the recent years, particularly by the US FDA. But actually, very few of these were evaluated for these subgroup performance differences. So we actually don't know if a lot of these kind of systems that are approved for use in healthcare, whether or not they have these performance disparities. And notably, one of these systems was kind of retrospectively found to exhibit these disparities in false positive rates across age and race subgroups. And then on the other hand, we also know that breast cancer screening is one of these processes that does kind of have this structural inequity behind it, where we know that, particularly in the US, there's a lot of documentation that there are these like substantial sociodemographic disparities that occur, not only in breast cancer screening, but also in breast cancer treatment and in mortality rates. But it's important to note here that we chose this case example, but it's not really intended to reflect like the real world utility of mammographic analysis systems, because there are a lot of promising, very well done studies that have found that AI use in mammography really can lead to better screening outcomes. But the goal of our paper and of our work here was to actually compare these algorithmic fairness scenarios and their impacts on outcomes to each other. And so we chose this case example because this is an application of AI in healthcare that does carry this kind of tangible and imminent risk of algorithmic unfairness, which will likely interact with kind of already existing structural inequality, which makes it a very interesting, I think, use case to study in this context. And so for this work, we developed this dynamic simulation to model this hypothetical population that undergoes an AI-assisted breast cancer screening process. We designed this kind of simulation based on clinical expertise. So we worked very closely with an oncologist in making our design choices here. And it was also very heavily informed by literature on these reported sociodemographic disparities, particularly from studies from the United States. And so I'll kind of walk through all of the simulation here. So the population that we modeled was a population of women in this kind of recommended mammography screening age range. And instead of, we didn't want to model kind of any real world demographic groups here. We had this, we modeled these pseudo demographic subgroups that we kind of broadly label as privileged and unprivileged. And so the difference between these two groups in our simulation is essentially just that they have these different levels of socioeconomic index on average. And so in our work here, the socioeconomic index is representing like an aggregate measure of socioeconomic factors. So that includes things like household income, or education level, or access to resources. So it's a very kind of simplified measure of socioeconomics, but this is kind of how these two groups are kind of broadly defined in this setup. And so within our population, essentially these simulated individuals can get breast cancer, and the breast cancer incidence rate we model as a function of age, and that's based on reported values from the National Cancer Institute in the US. And for all the individuals who do get breast cancer, they also have an associated mortality risk factor. So this is going to be defined for the individuals that do have breast cancer, and this value essentially represents like the relative severity of that disease. So you can think of it as kind of like loosely modeling cancer stage. And that risk factor is kind of sampled equally for the different groups. And so every kind of time step or simulated year in our simulation, we have all of the individuals in this population pool have the opportunity to undergo this AI-assisted breast cancer screening. But the probability of actually getting screened in a given year, we model as a function of socioeconomic index. So practically this means that a lower socioeconomic index corresponds to a lower probability of attending screening in that time step. And that is based on kind of these reported literature values. And so for all the individuals who do attend screening, we model this as this kind of shared decision-making process between an AI system and a radiologist. And so what this looks like is we have these kind of two independent decision functions, one by an AI, one by a radiologist. Both of these decision functions are dependent on mortality risk factor that I mentioned. So intuitively, this is trying to show how, maybe a more severe manifestation of breast cancer would be more easily identifiable in a screening situation. But we also have the AI decision as a function of subgroup membership. So this is going to allow us to look at these different algorithmic fairness scenarios, which I'll get to in a couple minutes. But then that final kind of decision function and that final diagnosis is going to depend on how much the radiologist actually relies on that AI decision. So we have this parameter alpha that is essentially modeling this degree of AI reliance. And then this final diagnostic decision comes as a function of that. And so after the screening process, all of the individuals who were screened negative, so including true and false negatives, returned to the population pool. For all those screened positive, there is a then follow-up stage of diagnostic confirmation. So this is trying to simulate like a biopsy exam for individuals who were initially screened positive in the mammography screening. And again, here we're modeling the likelihood of attending follow-up appointments as a function of socioeconomic index. So there was a slightly lower chance of attending follow-up given a lower socioeconomic index. And then all the individuals who were false positive, so incorrectly screened positive, they get sent back to the population pool, but they actually have a reduced probability of attending screening in the following year. And that was also kind of based on this breast cancer cohort study. And so after this diagnostic confirmation steps, for all the individuals who were kind of confirmed to have positive diagnoses, we go on to the treatment stages, but we have some individuals who are experiencing treatment delays as a function of their socioeconomic index. And here we have this treatment delay incurring an increase in the mortality risk factor. So this is trying to model kind of the disease progression while the simulated individuals wait for treatment. But eventually all of these kind of confirmed breast cancer positive individuals do undergo some form of treatment. All of them undergo surgical treatment, but there is an additional stage of adjuvant treatment, which the likelihood of receiving that additional treatment is also a function of socioeconomic index. And we have each stage of treatment reducing an individual's mortality risk score, to model the effect of that treatment. But we also have a concurrent decrease in socioeconomic index, and that is to model kind of the financial burden of receiving treatment, because we are kind of modeling this after a privatized healthcare system, as in similar to the US. And so we have this reduction in socioeconomic index associated with treatment, and that reduction is actually greater for the unprivileged group because we assume that maybe at a lower socioeconomic index, there's also kind of additional costs associated with getting treatment, including factors like poor insurance coverage or less of a financial safety net. And so that's kind of the main stages of our simulation. And then at the end of this kind of simulated year, each time step, we have that every individual in the population that has a mortality risk factor greater than a threshold value are assumed to be deceased. And then individuals either enter or leave this population pool based on kind of their age. And so now that we kind of walk through the stages of a simulation, we can kind of get back to our goal here, which was we wanted to connect algorithmic fairness and patient outcomes. And so for the first aspect of that goal, going back to this algorithmic fairness idea, I mentioned that our kind of simulated AI model makes its decision as a function of both the mortality risk factor and of the subgroup membership. And so what we did here was model these four different algorithmic fairness scenarios. So one where the model had these performance disparities between the privileged and unprivileged group. And then we modeled these different kind of algorithmic fairness constraints where we equalize either the true positive rate or the false positive rate or both. And very important here, one of our kind of design choices we made was that equalizing these error rates does result in a reduction in performance for the initially favorable subgroup. And so practically what that means is that in our naive model, for example, we have these kind of subgroup differences in both true and false positive rate. When we equalize one of these error rates, so for the true positive rate equalization, we have the unprivileged group true positive rate increase, but there is also a corresponding decrease in the privileged group true positive rate in order to kind of equalize those error rates. And this kind of trade-off or leveling down effect that I kind of mentioned earlier, it can occur when kind of certain bias mitigation strategies are used. So that's kind of why we want to model it here. And so similarly, when we're equalizing false positive rates, we have that kind of trade-off. And same thing when we have both of them equalize. And then from the patient outcomes side of this goal, essentially what we were measuring at each time step was the mortality rate disparity and the socioeconomic index disparity between subgroups. And so these are kind of our main outcomes that we're measuring in our simulation setup. And so getting into the results, the first thing we did was look at these outcome measures as a function of time. So over these kind of 50 simulated time steps or years. And so a couple things to note here. When we're looking at the mortality rate ratio, so this is the ratio between the mortality rate of the unprivileged group over the privileged group in a given year. We can see a couple things. One of them is that when we equalized only false positive rates, kind of interesting that this led to slightly higher mortality rate disparities compared to just having the naive model. And essentially this happened because this higher false positive rate that ended up being applied to the unprivileged group meant that there were less individuals attending screening in the following year, which meant that there was more untreated cancer and a higher progression of cancer within that unprivileged group. We can see that these mortality rate disparities were pretty effectively reduced by equalizing true positive rates, but this did come at the expense of a higher absolute mortality rate for the privileged group because of that kind of leveling down trade-off in the equalized odds and equalized true positive rate scenarios. The privileged group did have a higher kind of absolute mortality rate because of their lower true positive rates. And then from the socioeconomic outcome side of things, we did see that these kind of disparities between the two groups were actually reduced over time with the naive model and with the equalized false positive rate model. But this actually resulted from this trade-off essentially between the privileged group having to, pay for treatment expenses, which lowered their socioeconomic index on average, whereas the unprivileged group didn't have their socioeconomic index really impacted under these scenarios as much, but of course they had a much higher mortality rate under these scenarios. And so we also looked at these outcome metrics as a function of kind of the different ranges of true and false positive rate disparities in our simulated AI system. And so a couple things here is that we saw that true positive rate had a larger impact on outcomes than false positive rate. So you can see at a given false positive rate, there's kind of this very strong effect of varying the true positive rate, whereas we don't see as strong of an effect for the varying the false positive rate. And so this is kind of showing that there is kind of this disproportionate impact of true versus false positive rate on actual outcomes. And you can also see kind of similarly to what I mentioned in the previous slide, there is this kind of trade-off between mortality rate disparities and socioeconomic index disparities, where when you kind of decrease the disparities in socioeconomic index, that kind of comes with the corresponding increase in these mortality rate disparities. And then we also looked at kind of how our mortality ratios varied as a function of how much reliance that our simulated radiologists was putting on the AI diagnostic decisions. And so this degree of radiologist reliance, we can see it really actually strongly impacted the outcomes in terms of mortality rate ratio, but only when we had true positive rate disparities in the AI system. And so yeah, this on the x-axis, this AI reliance parameter of 1 indicates that essentially the radiologist would fully rely on the AI decision and vice versa. So you can see how, yeah, in the naive and the equalized false positive rate model, there is a very strong effect of this alpha parameter, but essentially no difference if the true positive rates were equalized. And then finally, we also compared outcomes for these different algorithmic fairness scenarios over a range of values corresponding to these kind of socioeconomic barriers that we modeled in our simulation. So how likely an individual of a specific socioeconomic index was to undergo each step, which practically corresponded to this range of proportions of each group either getting screened or experiencing treatment delays or receiving this adjuvant treatment. And so kind of the main result that we had from this analysis was with the screening, reducing the barrier to screening, because we can see how when we actually have kind of reduce that barrier enough such that we have the majority of the unprivileged group also kind of receiving screening each year, this had a very strong effect on reducing these mortality rate differences between the two groups. Whereas those algorithmic fairness constraints did have kind of a small effect in comparison to that. And so I think this is kind of an important takeaway from this slide is that we can see that achieving kind of these ideas of health equity does require more than just technological interventions. And so just some takeaways in terms of how this simulation and how this analysis kind of helped us to better understand this connection between algorithmic fairness and fair outcomes. One of these is that we saw that the true and false positive rate disparities had these very different impacts on outcomes. So specifically, the true positive rate had a much stronger effect on the measured disparities between groups. And so because the choice of algorithmic fairness constraints for a given model is a design choice, I think this kind of shows that these choices really should be informed from a clinical and a health policy point of view. Because in a case like this, we would likely want to prioritize true positives, potentially at the expense of false positives. But of course, it would still be important to kind of implement non-technical harm mitigation measures to reduce that impact of false positive rates. So like things like ensuring that there's rapid follow-up to kind of reduce any kind of emotional burden of false positives. And we also saw that socioeconomic factors have a large role to play in determining who actually gets to utilize AI systems in healthcare and in impacting the eventual outcomes of patient populations. And this is a variable that is very hard to quantify in the real world. And obviously we modeled a very, very simplified version of it. But I think we've seen very clearly here that it is a very important consideration and maybe something that we need to think about more when we're trying to understand the use and the effects of AI in healthcare. And we also looked at this analysis of how much the simulated radiologist relied on the AI decision. And I think this really exemplified kind of how clinical decision makers and their interactions with AI systems really play this like significant role in affecting outcomes. I think it's important to note that in our setup, we modeled this completely unbiased radiologist. But of course, we know that humans have unconscious biases as well, and they have been documented in having impacts on real healthcare outcomes. And so I think a very interesting area is this kind of shared decision-making process and the ways that human biases might interact with AI biases. And I think that area is kind of underexplored right now, but really crucial for actually really understanding the impacts of AI in healthcare. And finally, we saw that, even when we have models that are achieving these desirable metrics of algorithmic fairness, I think we saw very clearly that they can still produce these inequitable outcomes when they exist in a system that has this kind of embedded structural inequality. And I think this kind of speaks to the concept of technological solutionism, which is this view that like all of our problems can be, solved by technology like AI. And I think our work really highlights that AI systems can be tools for achieving better healthcare outcomes, but they can't address these, systemic challenges by themselves. And they do need to be accompanied by changes in things like public policy and healthcare delivery as well. And so, just to wrap up here, I hope this work was really able to highlight that this kind of interdisciplinary and socio-technical perspective on the fairness of AI in healthcare is really essential for ensuring that we are developing and implementing these systems in ethical ways that actually lead to improved outcomes for patients. So that's all I have, and thanks, and I'm happy to take questions if there are any.
Hi, thank you, Emma, for such a great talk. That was a really interesting showcase of how we can use these sort of simulations to quantify how useful our algorithms are going to be in practice. Um, so I'm going to open the floor up to any questions. You can either type them in the chat or feel free to unmute your microphones or raise your hand, however you prefer. And maybe to start off with, I'll ask a question. So you mentioned that the clinician, there's a parameter that you fix, I think you call it the AI reliance parameter. And I was wondering if you considered having this change over time. So having the radiologists perhaps change how reliant they are on the AI, maybe for different subgroups, and what you think the downstream effects of that would be.
Yeah, that is definitely something that we thought about, and I think it's very important and would definitely make kind of um, this whole kind of simulation approach maybe even a bit more realistic. I think we chose not to introduce this dynamic aspect to this work just because it adds kind of this whole other layer of complexity, right?
Yeah.
Where you have to, decide kind of what this kind of dynamic relationship really is. And I think because there isn't a whole lot of research on that right now, it's maybe not necessarily super easy to decide how to model that. But I think that would be a really, really interesting kind of extension of this work is actually looking at more into, yeah, this relationship and interactions between like clinical decision maker biases and AI biases because I think that's definitely something that would be occurring in the real world. Like, the nature of kind of human AI relationships will be very dynamic, and obviously that will be able to impact kind of patients and outcomes a lot. So I think that's definitely something that should kind of be explored in this space in the future.
Are there any, does anyone else have any questions? Oh, Brie, yeah. I think you're muted. Um, while we wait, I have another question. I was wondering if you could talk a bit more about how you sort of designed the simulation, because I know you said you talked to clinicians and looked at like what's in the literature, but if you could go into a bit more detail on like maybe exactly how you decided who to ask and what to look into.
Yeah, that's a good question. So we Um, initially kind of came up with the idea of looking at breast cancer as a case study because of kind of what I mentioned in the motivation, where, this is kind of a prevalent use case of AI in healthcare. And I think kind of the main factor that there are so many kind of already existing and reported demographic disparities in breast cancer screening. That's kind of why we thought it would be a nice kind of way to look at kind of algorithmic fairness and kind of existing inequities and how that interacts. So then we reached out to an oncologist at our university who was really helpful in helping us to kind of figure out which stages of this whole process that would be relevant to model. So obviously the stages we modeled are very simplified. There's going to be a lot more kind of processes and variables that occur in the real world. Like we didn't necessarily model kind of patient-specific factors like cancer subtype or that kind of thing. So those are the kind of questions that we would ask. But our collaborator was really good at kind of understanding our goal, which was, comparing these algorithmic fairness scenarios. So that kind of he helped us to, understand what was like really important, pertinent that we needed to model, versus what was kind of just necessary to kind of achieve our goal of, comparing these scenarios. So he had a lot of kind of input in actually looking at the specific stages to model. And then most of the parameters that we use, like in the different decision functions and models, were all kind of informed by these reported like literature rates. So in terms of things like percentage of the population to get screened or differences in kind of these different demographic groups in terms of rates of screening, for example. So yeah, that's kind of a collection of, literature informed and then kind of clinical informed design choices. It's kind of how we set the whole thing up.
Thank you. Brew, I think you should be able to unmute yourself now if you want to ask your question.
Ah, great. Can you hear me?
Yes. Yes, I can
Yes.
hear you.
Awesome. Okay, thanks. Yeah, this is great work. I'll just read out what I posted in the chat. So yeah, I think it's so important to tie the impact of algorithmic decision making, I guess, to the actual health equity impacts, right? And I think people always like talk about it, but actually it's quite hard to draw that like connection between the two. So this is really important work. And I was kind of curious, and it's a tricky question, but like in the like the real world, if you had real data, like how might one like go about drawing that connection? I'm just curious to hear your thoughts because I've thought about it a little bit, but I've not really come to cover an obvious solution.
Yeah, it's a bit challenging. I mean, when we were first kind of setting up this whole simulation, I mean, there is kind of this whole other, body of literature that is coming from this more like epidemiological standpoint where they really are trying to model kind of like very specific kind of patient characteristics and very specific kind of treatment effects and outcomes. So initially we were kind of looking at that and wondering if we should kind of go in that direction, but I think because kind of our goal was not necessarily to faithfully model a specific population, but to, compare these different scenarios over time. That's kind of why we went for this, more, I guess, simplified approach or kind of more abstract approach, I guess is the right word. But I think if you did have kind of this real world data, I think it's you're definitely be able to integrate kind of, I guess, as much data as you had available. So for example, if you had information on kind of like these kind of screening rate disparities or in terms of like, yeah, how much maybe a treatment is like reducing the impact of mortality. I think these are all kind of factors that you could incorporate, but I think it's just hard from that perspective where if you're saying that you are modeling a specific population, I think you get into the territory of, the takeaways from your paper might be kind of understood as like this is really kind of like what what would happen in the real world and like from more epidemiological standpoint. So I think that's kind of the line that we had to toe a bit with this paper is really trying to emphasize that it is abstract. But because I think if you did want to really like faithfully model a real population, you would have to have kind of all the parameters that you need for all the different stages, right? And I
Yeah.
think that's a very difficult thing to try and data to collect, especially in this case where, we want these essentially like counterfactual scenarios of different algorithmic
Yeah.
fairness
Yeah.
I think that's a bit that's tough to collect real data for that. So that's kind of why there's this kind of balancing act in like real data versus like abstract data and that kind of thing.
Yeah, absolutely. That totally makes sense. Thank you. Great talk. Thanks.
Okay, thank you. I guess if there's no other questions, we can leave it there. So thank you again, Emma, for giving this wonderful talk, and thank you everyone for joining. See you next time.
Yeah, thank you.